Good afternoon. Welcome back to UCSF Medical Grand Rounds. I'm Bob Wachter, Chair of the UCSF Department of Medicine. Welcome, as usual, to our live audience in the department throughout UCSF and to our partner sites throughout the UCSF Health Network. We'll post this video tonight at about 7:30 p.m. on YouTube, and I'll tweet out the address. Our previous Grand Rounds in this series have now been viewed nearly 800,000 times. Before we get started, a quick program note. We've been doing these Grand Rounds weekly since mid-March. We're going to take a little break. Next Thursday at this time, there'll be a presentation by a UCSF campus on the future plans for the Parnassus campus, including the new hospital and new research building. So that will substitute for this for our live audience. Then we'll take a couple of weeks off for Grand Rounds for our entire team, and we will come back after Labor Day on September 10th for another COVID Grand Rounds. Starting at that point, we'll alternate every other week doing a COVID presentation versus a more traditional medical presentation, unless things heat up in COVID, in which case we will take over some more sessions. On to today's session. A few ground rules, as usual, are here. You'll be on mute. If you have questions, type them into the Q&A box. We'll screen them and try to get to some of them. We're now about 6 months into the US experience with the pandemic, and while cases are down a bit overall, we're still seeing extraordinarily high rates of cases and of deaths. Notwithstanding the Russian Sputnik vaccine, it's likely that we're still a year away from a widely available game-changing therapeutic or preventive approach. We're now over the early panic stage that we all experienced in March and April, what I think of as the complacency stage of May. And hopefully we're moving toward the latter parts of the summer surge phase that we've had for the last 2 or 3 months. While much of our approaches involve Pandemic 101, searches for vaccines, medicines, and traditional non-pharmacologic strategies, we're starting to see some out-of-the-box thinking, new paradigms, new approaches, new ways of attacking COVID. And today we've chosen to highlight 3 areas in which these new approaches are being proposed and implemented. I think the presentations will be eye-opening, maybe a little controversial, and will demonstrate the importance of attacking this pandemic in creative ways. The presentations will go till about 1:20. The first one will be from Michael Mina. Michael is Assistant Professor of Epidemiology at the Harvard Chan School of Public Health and a core member of Harvard's Center for Communicable Disease Dynamics. It will be on an issue that was first I became aware of when Chaz Langley presented here about 3 weeks ago, the potential value of changing our testing strategy, moving from a highly sensitive PCR-based testing strategy to one whose backbone is faster, cheaper, more scalable, but less sensitive viral tests. Michael will speak for the first 30 minutes or so, and although he looks live in this picture, we actually taped our presentation with him a couple of days ago. He couldn't be available right now, so don't put in Q&As for his session. It's already on video. We'll then shift to 2 live presentations. The next will be a presentation by Trevor Bedford, who's Associate Professor of Epidemiology and Genome Sciences at the University of Washington and at the Fred Hutchinson Cancer Center. Hi, Trevor. Trevor works at the interface of evolution, epidemiology, and immunology, and he studies computational and statistical methods to understand viral dynamics. Trevor, who has 260,000 Twitter followers, and I am one of them, quite avid, proposed a fascinating hypothesis on Twitter a week or so ago related to the dynamics of herd immunity as it relates to COVID. So I've asked him to discuss it here, and we'll do that from about 12:30 to 1. Finally, while much of our approach to COVID hinges on the sciences of virology, immunology, epidemiology, clinical trials, and the like, at its core, most of our response depends on attitudes and behaviors. How do people assess their own risk? How do they assess the risk of those that they care about? Are people empathetic about others who have risk or who are sick? Do people understand what it feels like to care for patients with COVID as a clinician or as a family member? And given the evidence of disparities in COVID and the coupling of this pandemic with the vivid examples of racial injustice we've all seen, how do we process all of this? One can argue that another discipline, that of humanities, and particularly the use of narrative, has a unique role in laying out these issues and helping us contextualize all of the data, which can be dangerously bloodless. For that, we're lucky at UCSF to have a group of faculty and trainees who've done pioneering work in this area. We'll hear from Emily Silverman, who's a faculty member at Zuckerberg San Francisco General Hospital, who a few years ago launched a storytelling effort called the Nocturnists, which she's used, converted over the last 6 months to focus on COVID, both through live storytelling and through podcasts. Along with Emily, we'll hear from another of our faculty members, Ashley McMullen, who's based at our VA hospital. A few months ago, Ashley launched a podcast within the Nocturnists called Black Voices in Healthcare to explore the unique issues that we're all thinking about and struggling with around racial violence, racial justice, and how it all syncs up with COVID. So this segment, which I'm really looking forward to, will go from about 1 o'clock till about 1:20, 1:25. So with that, we have an ambitious and wide-ranging program. I hope it gives you a sense of the role of creative new thinking in attacking this pandemic. So we will get started with Michael Mina and a new approach to testing.
All right, well, thank you so much for having me here. It's great to get an opportunity to talk in this Grand Rounds. So I'm going to be speaking today about COVID-19 testing strategies and how we can use testing for surveillance and more importantly for control of epidemics that extend beyond how we normally think of COVID-19 as a tool for diagnostic purposes. So I like to start out with this slide here just to drive home, if anyone continues to think that this virus might be disappearing sometime soon, the future doesn't look so grim if we look to what we have known in the past based on seasonal coronaviruses. The future starts to look a little bit, as we move into the fall and winter, we are very nervous that we're going to see increased cases of this virus. So these are seasonal coronaviruses that I'm showing on the two slides on the right here. On the left, it's a little bit out of date at this point, but just to show that, of course, we all know cases are continuing to climb for this virus. On the right are what we know of the seasonality of normal coronaviruses that are traditionally circulating in the human population. And what we can see here more than anything else is that there are massive spikes in coronaviruses that usually come around November and December. And so if we don't yet know what exactly this virus is going to hold in store for the winter, we don't fully understand and appreciate all of the underlying biology that goes into driving these dynamics. But I think that one of the major takeaways here is that we need to continue to act now to be prepared for what's going to potentially happen in the fall and, of course, further into the winter. To lay some groundwork for what type of surveillance and outbreak control testing I'm discussing, I just want to point out briefly that there's, of course, two different types of tests. Each of these have multiple branches within them, but there's testing for the virus and then there's testing for antibodies. Testing for the virus is extraordinarily important if you're trying to use it as a modality to contain and control outbreaks and stop transmission chains when you know that outbreaks are occurring. And this is because you have to be able to identify people who are infectious and ask them to stay home, for example, and it serves to stop the spread at that level. Antibody testing is an extraordinarily important tool from a public health perspective, and it is one that has been traditionally used for monitoring outbreaks and pandemics and epidemics and things along those lines. But because the antibodies usually develop a week or two after somebody has started to present symptoms, generally they are not going to be useful as tests to stop transmission chains at their source, but they can be used as very powerful tools once population prevalence is low for what I call peacetime surveillance, to keep an eye on a community, large communities, to be able to know where outbreaks are emerging, and then you can jump in with virus testing and other non-pharmaceutical interventions or pharmaceutical interventions to try to mitigate the spread. So for the rest of this talk, I'm going to be talking about virus testing, and despite talking about sort of these rapid tests that I'll discuss at one point, I just don't want people to confuse them with the rapid antibody tests that were being built back in April and March, but some of them turned out to not be such high quality. So if we think about test characteristics, we usually think about test sensitivity has been sort of first and foremost in a lot of the discussions surrounding testing for COVID. Of course, specificity is also part of this framework as well. I'm not going to talk too much about specificity. Certainly, if there are questions, I can discuss those. But then cost, which I essentially liken cost to frequency of being able to run perform the test. And then speed to get the results back. How long does it actually take? What's the turnaround time from the time somebody actually gets the swab stuck into their nose to the time they get the results? Our priority has definitely been, in this country anyway, sensitivity first and foremost, and then cost, and as we all know, speed has been abysmal lately, with some people waiting numerous weeks to get a result. And as far as I'm concerned, from a public health perspective, if you're waiting more than a few days, that result may as well just be thrown away in a lot of regards. So a fast test that might give results in minutes and that is very, very sensitive is likely going to be expensive. And we're seeing this with tests like the Abbott ID Now and the Quidel and BD Veritor. These are tests that are going to work well. They're going to pass FDA EUA approvals. They're going to be true diagnostic tests, but they're also going to be limited. They require instruments that cost hundreds or thousands of dollars. And then they are going to have individual cartridges that are very highly manufactured and are also going to increase the price, which is going to necessarily decrease the frequency that they become available to the population. But what about a test that gives very fast results, is inexpensive, could be used truly daily by most people, but is 1,000 times less sensitive at the molecular level? Does it matter? And the question is extraordinarily important because these tests can be available today. And so to answer this question, we have to really look at what happens within the body and in terms of virus growth. So normally what a physician sees when they get a result back for a patient with coronavirus is that they'll see something along the lines of positive or negative. It doesn't come with much more information. And this has been, I think, a real travesty of how we are reporting our results. I've written about it in the past, and we'll have new information coming out about it in the future. But essentially, I feel very strongly that we should be giving clinicians from the laboratory CT values, even if imperfect and not, they are still very valuable. The CT value is, of course, inversely proportional to the virus concentration. And what we know about this is that as somebody gets infected, there's usually an incubation period where even the most sensitive of tests available today might still show up negative. Once somebody turns positive with what I'm calling here is the high sensitivity test, or we might think of it as the gold standard qPCR test, maybe their viral load is around 10 or 100 viral copies in that swab. But very quickly at that point, the virus is in sort of what we would call deterministic exponential growth. It's growing very rapidly. And within hours, maybe a day or so, the virus will blow through many orders of magnitude as on its sort of steady march, exponential march upward in viral load. And it will pass the thresholds of even a test that is 100 times or 1,000 times less molecularly sensitive than a viral PCR test. And it's at about that time that somebody actually starts to be able to transmit the virus. And so this is really important because the differential between the high sensitivity and what has been called in the media and elsewhere a low sensitivity test is actually a matter of hours and maybe a day, but it's not a particularly long time. At that point, people are transmitting the virus. And what we normally find when we're measuring and finding that a test is low sensitivity is we're actually measuring down here in this yellow period of time when somebody has actually, for the most part, cleared their virus. And there's a lot of viral RNA that's just continuing to stick around inside of the nasopharynx. It could potentially be, we're not quite sure what exactly is leading to this. It could be some very low level replication, potentially of non-viable virus. But either way, we don't believe that it's transmitting. In general, this is even by the CDC's own admission that after about 10 days, it's not worth testing people anymore because they will still oftentimes be positive, but will no longer be transmitting virus, and they could probably leave quarantine. And so this is, the dynamics here are very important because what they suggest to us is that most of the loss in sensitivity that we're getting when we evaluate these different tests is really happening at a period of time that, from a public health perspective, saying nothing about the diagnostic use, but from a public health perspective, would probably not be very valuable to help with transmission chain mitigation and stopping transmission, because people are already done with their transmissible period anyway. So if we take all of this information and we put it into population level mathematical models, which we have done with a number of different frameworks. What I'm showing here are results from an agent-based modeling framework. The two different colored bars are what we would call the PCR test, or the high sensitivity test. And then the darker bars are what might be thought of as a lower sensitivity test. And we've done this with 100 times worse sensitivity, 1,000 times or 10,000 times lower molecular sensitivity. And what we see is, by far, the most important piece of the testing regimen that we need to get right here is not the exact metrics on the test itself, if your goal is population mitigation of transmission, but it's the frequency that the test is being used. And if we can use a test every day or even every 3 days, the actual requirements of test sensitivity play only a very, very minor role. And what we can see on the right here is that, relative to a scenario where you've just let the epidemic sort of move through the population with no testing, and you just have people quarantine when they feel symptoms. What we can see here is that if you test with either of these tests daily or every 3 days, you will essentially stop all transmission at the population level over the period of time that the epidemic would progress. As we start to move out to weekly or every 14 days, we start to have a much more difficult time controlling the epidemic through testing strategies. And so what this is really suggesting to us is that sensitivity should really take a backseat to frequency when it comes to testing as a public health tool. We can also look at the turnaround time of these tests. And what we see is that in terms of turnaround time, where I have, again, the frequency of testing are the big groupings, daily, 3-day, weekly, or 14-day. But then the 0, 1, and 2 is how long does it take to get the result back? And that's very important here, because a lot of testing, when we did this, we hadn't even had it in our minds that we might have test results getting back to people 7 days later. What we can see is, even at 3-day testing, if you're not getting the result back within 48 hours, you're really losing a lot of opportunity to prevent infections at the population level. Certainly once you're at weekly testing, if you're spending 48 hours to get the test results back, then you're barely able to reduce the epidemic. And to put this in context, this is weekly testing of nearly 100% of the population. And this includes all the variation and sort of our ability to detect cases and all of that. But in the US right now, we're not doing anywhere near testing of the population of the US weekly. We're running around 800 or 900,000 tests a day across the US, which doesn't come close to any of these scenarios. So we've been really pushing for a whole different way of thinking about how to produce tests that doesn't require laboratory sort of testing, or these very high sensitivity tests, but can we actually get lower sensitivity tests that will give you results back here in this case where we have 0, that would be the equivalent of giving results back in 10 or 15 minutes to somebody, and they could use it, for example, every day as they're brushing their teeth. And so I think to really, to prevent outbreaks across the population, these results suggest to us that it's more than okay to sacrifice molecular sensitivity for high frequency testing, which would ultimately be much, much better to detect infections. And so I think that we should really start prioritizing cost and frequency much more so than sensitivity in terms of the tests that we're deploying. But why don't we have these tests today? Unfortunately, all of our tests, we don't have a public health framework in this country. Public health has been largely ignored for clinical medicine. And in this case, I would say that we have this situation happening where we just don't have the framework, we don't have the regulatory pathways, and frankly, we don't have the language to even consider a test whose primary objective, or which primary objective, is one of public health and not individual health. And so because of that, at the FDA, for example, it requires 90% sensitivity, which is really based around, compared to PCR, which is based around this idea of diagnostic medicine. And what I'm showing here on the bottom right are just CT values from the last 8 weeks in Massachusetts. And this is very, very important because what we can see is the CT values from the last 8 weeks these aren't fully across the whole state, but what we see is the vast majority of specimens that were collected had CT values well above 30. So that means the majority of tests that we're actually detecting people as positive are probably well beyond their period of transmissibility and are in the recovery phase of their infection. So, and this is because we're not doing frequent testing. So we're only capturing people, what I have here, in this long tail of PCR positivity, which is past the period of transmissibility. So what we're calling for is really to have frequent daily testing, which would almost guarantee that you detect most people on the first or second day that they are transmitting virus, versus a very sensitive PCR type of test, which is performed infrequently, with the most likely scenario being that you miss people altogether, or at the very least, you miss their transmissible period, and then you end up quarantining them erroneously and sending contact tracers down rabbit holes that they don't need to go down because they're looking during the wrong time period anyway. So I think it's important to point out that there's different sorts of rapid tests. There are what I consider as the Nespresso machine model of tests, and these are the tests that are essentially could get to the quality and reporting structure that the FDA currently wants for at-home tests. These will be things like that are already available, like the BD Veritor, the Quidel instruments, but they're going to be expensive. They might work extremely well. They might be able to report back to authorities and give negative and positive results on a daily basis, but they're necessarily going to be limited. However, these are what the FDA currently wants. What I want to see is that we get the instant coffee version of these tests, where we have tests that we can produce in the millions that won't be limited by the ability to produce the instruments. They might be a little bit lacking in their molecular sensitivity, but the trade-off is that you'd get to use them every single day. And so this is really where we're looking at in terms of rapid antigen tests today. And unfortunately, what we can see is this hasn't really been picked up at the level of the FDA at this point. Brett Giroir recently said that this would be catastrophic if we release tests that had only 30% the sensitivity of PCR. But again, PCR, the majority of cases that we're finding are past their period of transmissibility, and most likely these rapid daily tests will be much more sensitive than that to detect people when they are transmitting virus. And to put this all in context, what I have down here on the bottom, my best estimate is that currently with our surveillance networks that we have set up, we probably have around a 3% sensitivity to detect cases in the US right now in time to act on those cases. And so currently this is what we're dealing with. And I think that if we can get to 80% sensitivity or 90% to detect transmissible people and ask them to stay home, then that would be a huge gain that would most likely prevent outbreaks. So I can stop there, and I'm happy to take questions.
Perfect. Thank you so much. That was terrific. I'm a little bit unclear on whether these tests exist today or do not.
Yeah, so
the nuts tests.
So these tests can exist today. They do in large part. In fact, we could just take the example of the BD Veritor system. Underlying that system is actually a rapid paper strip antigen test. But in order to improve the sensitivity sufficiently to get it FDA approved, they had to essentially have a reader read it out. There's no chemical modification happening inside of that. It's just purely a reader. And they had to put it into a plastic cartridge. But technically underlying it, it's just a paper strip test. There's the SD biosensor and the Rapigen test. These are both made in Korea. They seem to work very well. I haven't evaluated them myself, but they have they have been CE marked in Europe, and so these tests can be available. And then there's a few other companies that are starting to make them today as well. And so the short answer is yes. What I would add though is these can essentially, I don't see another solution at the moment. We're not going to get vaccines tomorrow. We aren't going to, clearly the mechanisms that we're using currently to try to control this virus just aren't working in the US. And I do think that this is simple technology. It's lateral flow assays that have been around for a very long time. And this is the kind of thing that we shouldn't be asking, do the companies have them ready to build at this point? We should be saying, how do we get the federal government to just use all of their might and all of their resources to just start making these? And for a fraction of the cost of the most recent stimulus bill that was passed for coronavirus response, we can have every American using one of these every single day for a year.
That's your vision. Is I wake up in the morning and I test myself, and if I'm positive, I stay home, and if I'm negative, I go out and do my thing.
Yeah, I like to think of these as transmission indicating tests or transmission blocking tests, and they are, you still would act the same way that you'd act otherwise in terms of wearing a mask, social distancing, whatever is your normal routine. The only thing that will change in this case is that if you get a positive signal, you don't go out.
Mm-hmm. Would you envision, I mean, as you say, one of the things that you're doing here is trying to push us to abandon, in some ways, the medical diagnostic paradigm to a more public health paradigm. The medical paradigm would say, all right, we screen with a less sensitive test, and then we do the better test if you're positive. Is that part of this, or you abandon that idea as well?
No, I wouldn't want to say that we abandon any bit of the diagnostic infrastructure that we have. Diagnoses are still crucial. If you're a physician and you have a patient sitting in front of you who has signs and symptoms of coronavirus, absolutely you need the absolute most sensitive specific test that you can get. In this case, this is what I'm trying to suggest is we create a whole new way of thinking about how a test can be used and viewed that doesn't have to do as much with individual health, but this is a test whose primary outcome is population health, which, as far as I'm concerned, if we can reduce population incidence of this virus, then everyone's individual health becomes much better and people become much safer. And so I think that we need to keep the diagnostics in mind, and we need to start really changing the message that this is not a diagnostic test, and it is a whole different way of thinking about what a biological test could be. And maybe we have to think of it almost as a biomask or something along those lines, where they don't need to be perfect. And in many ways, this reminds me a little bit of what happened with masks in March and April, where people, the general theme was, if it's not an N95, don't wear it. We couldn't trust people to not feel a false sense of security. And of course, now we say, if you have anything that looks like a mask at all, wear it. And I want us to get to the same point, to recognize, to just come to grips with the fact that we're not going to diagnostically test our way out of this epidemic. And a new way, this is just it is a test that people are using, but it's really should be thought of more as a way just to block transmission, in the same way that we think that a mask can be served to block transmission, even if imperfect.
And it seems like, I mean, part of the paradigm here is that even though it is less sensitive, it is perfectly sensitive enough for what you care about, which is, are you infectious? First of all, is that right? And second of all, is there a correlation? You didn't talk about the degree of illness or how likely you are to get very sick. Is that also true? If you ping positive on this test, you have a higher level of virus, and not only are you more infectious, but do we know that you're actually more likely to get sick, or are those things in sync as well?
Well, we've recently looked at a lot of data of our CT values from symptomatic and asymptomatic individuals. We haven't seen a big difference between the CT values of the two. So I don't know that I would want to go down that road and suggest that it would be indicative of that. What we do know is that most people who get infected with this virus during their viral replication and their growth period of the virus in their body, they generally exceed the limits of detection of these paper antigen strip tests. So I think that they would do a very good job at capturing most people in the first day that they might be transmissible, or even the day before they become transmissible if using it every single day. And the reason why we don't want to think of it as a diagnostic is if there is somebody who gets infected with this virus, but manages to essentially control the virus in large part, never gets to a place where they are potentially transmitting it, then it could be that these transmission indicating tests never actually turn positive for that person. So it's not really a diagnostic, but the good thing is that most people who would be transmitting, in particular super spreaders, will probably be spewing out a huge number of viruses. And these tests will turn positive. And to put it in perspective, the PCR test detects virus down to around 100 viral particles per mil. When we look at the range of which people have virus in them during transmissible periods, it's not 100 and it's not 1,000. It gets to 100 million, 100 billion, or a trillion viral particles. So all of our discussion about sensitivity has all ranged at this 100 level, 10 to 100 viral particles, when the real importance when it comes to epidemics is detecting people probably above 1 million viral particles or more.
Just to get a little more practical, you didn't talk about the mode of collection. Am I spitting on it? And then the mode of reading, is it a pregnancy test equivalent? Am I looking for a color change? And then you implied it's very cheap, but are we talking about, a quarter a day, $1 a day, $5 a day? Any sense of that?
Yeah, so the mode could be saliva, and I know that there's different tests that are being developed. Some use saliva and some just use an anterior air swab into saline. So I think of it as kind of the complexity of taking in and out your contact lenses. Maybe you have a little squeezy bottle of saline that you use every day, and you put the swab in there, and then you drop the little paper strip in. Capillary action pulls it up, and just like a pregnancy test, yes, you look for a line to turn a color. My expectation is that these should be around $1 a day. I think that they can be produced for less than $1 a day if the big companies get involved, or if the US government takes it over and starts producing them. And so a lot of people say, well, that's $300 million a day for the United States. That's totally absurd. We can't do that. But when you start talking about what we've spent with coronavirus, $300 million a day for a full year of daily use by every American almost ultimately is just a small fraction of one of the stimulus bills that has been put forth. So I think it's fully doable from a financial perspective.
Has any country in the world embraced this idea and is using it today?
So not yet as in this way. And I think this whole idea of truly daily testing to stop transmission chains and really use testing as a transmission blocking agent. We came out with a study about a few months ago that kind of pushed this, what I showed some of the results from. And that sort of, I think in general, started some of the conversation, or at least started to accelerate the conversation. So since then, and since we've been gaining some more traction in the media and Congress and Senate and things, we have been hearing more and more countries wanting to get involved. And so on any given day, I'm getting calls from prime ministers and princes of countries and things from around the world asking, how do they get the tests and how do they start using this tomorrow? Unfortunately, my response continues to be, well, most of the manufacturers that could be producing them aren't bothering to at this point because there's no clear FDA approval pathway. But SD Biosensor and Rapigen are two Korean companies that are starting to really scale up production. And I believe Senegal might be starting to do it. And we've been talking with a number of different countries about carrying out these types of studies or these types of programs.
But today, when you hear about ball players or visiting the president, that kind of thing, using rapid tests, none of them are these. They're still fast versions of the more sensitive tests. So this would really be a change in paradigm.
Yeah, exactly. Yeah.
So it seems like you've gotten a lot of traction. I hadn't heard of this idea until a couple of weeks ago. It feels like it's gotten a lot of traction. Are you hopeful or not in terms of uptake, and sort of maybe parse your answer of from the rest of the world and then the United States?
I think the rest of the world could certainly, much of the world has many fewer regulations. They have a greater sense of public health as a goal in mind. And I think that these things could be rolled out in many parts of the world as we speak, and they are starting to be. In the US, I think that I'm hopeful that we will get there. We've gotten a small army of senators and congressmen involved and very interested. The media has certainly been very interested in applying pressure, and the NIH and CDC have both been, at least from heads of those or leaders in both of those organizations I've spoken with, have been very, very supportive. And the question is, okay, well, how do we move it? What needs to happen? And it really comes down to the FDA. And unfortunately, the FDA is the regulatory body for these types of tests, but they don't have a remit to evaluate public health tools. So there either needs to be a whole new pathway at the FDA to say, okay, this is a pathway that you're going for a public health claim and not a diagnostic claim, so it won't be health insurance reimbursable, et cetera. Or the FDA needs to say, this is a public health tool, they wash their hands of it, it's off their desk. If that happens, which is not what I'm hoping for, I'm hoping that they want to keep control of authorizing them. But if it does happen that they say this doesn't fall under our purview, then very quickly we need the CDC or the NIH or some other authority to come on board and say, okay, we're going to create some sort of certification program. Because the last thing we want is for the market to become flooded with tests that really don't work and have this program fail. So I'm hopeful that the FDA will decide that it is within their purview to create a pathway to evaluate tools whose primary goal is one of public health instead of individual diagnostics.
Is there any analogy that you can think of in kind of the world of public health where there is a tool like this and we figured out what the regulatory pathway is for that?
To be honest, not really. At least not tools that are regulated. So thermometer testing is, I guess, in the sense of COVID, people are using it as that. It's not a good alternative. Masks are an analogy, I suppose, but in our culture, in our language, the moment it's a test and not sort of a mask kind of thing, it becomes seen as a diagnostic. And I've been trying to rack my brain if there is an example. Maybe rapid HIV tests would be the closest, and I would say that there is a sense in the HIV world that you getting your own, that giving yourself an understanding of your status is really a public health good, and it allows people to make better decisions about their actions, and that's kind of what we're going for here as well.
Yeah. Well, thank you for pursuing this line of reasoning. My sense is I don't know how much traction it would have gotten except for the delays. I mean, it feels like if we could get 2-day turnaround on old style, maybe overly sensitive tests, I'm not sure the market for an alternative way of thinking about this would have opened, but it clearly has now. I mean, this current situation is disastrous. And so that creates an opportunity to think about this in a new way. And I really appreciate you helping us to do that.
Well,
so good luck with it.
Yeah.
All right. Thanks so much. Really appreciate it. Let's switch over to Trevor Bedford, who will talk to us about herd immunity, a loaded term if there ever was one that's been hotly debated throughout the course of this. And Trevor's been doing some really interesting new thinking about what it means now that we have more experience with COVID. So Trevor, thanks so much.
Thanks, Bob. And thanks for the opportunity to present here. I have to admit that this is going to be a bit rougher than maybe most of my talks. So really, most of my research focuses on genomic epidemiology and evolution of viruses such as SARS-CoV-2. The specific angle on population immunity or herd immunity is kind of pretty basic look at infectious disease dynamics and kind of maybe some more obvious things that we can see from the data here, but hope it's still interesting. So, oops. there we go. So there's this very classic conception of population immunity and the effect on transmission, where we'll have the R naught of the virus that I think people are going to be quite familiar with. It's going to be the number of secondary infections that one infection causes. For SARS-CoV-2, for COVID-19, we think that's somewhere between 2 and 3. So I'm going to be using 2.5 for the R naught throughout the talk. And then what happens is that that infected individual is going and meeting random people in the population. And so the number of actual infections that causes depends upon meeting susceptible individuals as opposed to immune individuals, recovered individuals. So the number of secondary infections caused at a particular point in time will be R naught times the fraction of the population susceptible. So very simple equation. And what this means is that more and more of the population are immune, RT drops and drops, and this is where we get this normal 60% herd immunity threshold. That is the normal number that people throw out when they talk about herd immunity. And so this would suggest that yes, that if our population is acting in such a fashion that that RT is 2.5, that we would need 60% of the population immune to suppress the transmission. And so we can kind of see this effect here in a very simple simulation. This is this kind of classic SIR model, just as a demonstration, where we start with 100% of the population susceptible. We have an epidemic happening here in red, and then as that occurs, we move individuals from being susceptible. They get sick, and then they recover, and they have immunity. This is important. And then over time, the recovereds build up, and the susceptibles deplete. And we see here we have this peak of the epidemic here. That occurs, again, in this case, when we have 40% of the population that is still susceptible. And we can see this here as well, that RT drops over the course of the epidemic, first at 2.5, then it goes below 1 as we're falling here, and then the very peak is going to be where RT equals 1. And so this is this very classic picture here. However, in the case of COVID, as well as other diseases, human behavior plays a huge role in determining transmission. So R naught is not fixed, and we have a massive ability to modify this, to modulate this. Early in the epidemic, once we kind of knew that things were spreading, we saw this immediate strong reduction in mobility, people staying home, lockdowns, et cetera. And then we and others, this is work from IDM in Washington State, looking at early on in the Washington State epidemic, if we look at mobility from Google, Facebook, et cetera, compared to RT estimates, there's this really nice correlation early on where there's this strong reduction in mobility and a strong reduction in RT. And so just following that up a bit, if we go from, say, March to July, and I'm going to really, throughout the talk, focus on 3 different states to just make things clear: Florida, Arizona, where we've had the recent surges, and New York is kind of a comparison here. And so here, if we look over the course of March, we had this really large epidemic going on in New York. We still have increasing caseloads in Florida and Arizona. New York starts to decline over the course of April to June. We have this plateau in Florida and Arizona, and then this uptick later on in June. And we can look at how this affects RT. So we see early on that we get this like 2.5 level that we'd expect, perhaps even 3, where there's this really rapid amplification. Behavior starts to change. RT really strongly drops. We are starting to suppress the epidemic, things are going down, but then in the states that reopen earlier on, in Arizona and Florida, RT starts to tick up again. And so we have in May and June going above 1, and we start to see these epidemics because of that. If we look at societal responses again, we can see this is just a couple of my favorite things to look at. One is open table reservations, just as a measure of how many people are going out to eat at restaurants. We see this immediate dive in restaurants in all 3 states, and then the 2 states that start to open up, this slowly climbs again. Similar effect in Google mobility for people looking up directions to go to retail and recreation. And we see this, again, this huge dive, and then a slow tick up after that point. And this pattern fits with effects in RT. So this is a phase plot that maybe some people are going to be familiar with, where we look at two different variables and see how they change over time. So we have early on, RT is high, and a lot of people are going to restaurants. And then over this first phase, there's a rapid decline where both RT and going to restaurants drops, and then a very slow increase again over here. And so we don't get back to the same point because there's other things going on, masks, people being more cautious in general, but there's still then this correlation here between societal behavior and RT. We get a similar picture in Google Mobility where there's this immediate mobility drop followed by a mobility increase as kind of things start to slowly come back online. And so I think it should be obvious and agreed upon that the way that we're behaving in society will affect R naught and change our T values. This just seems very clear. And so what we're left with then is we start to kind of now add back in immunity here, that if we wanted to get to RT, I have this very simple equation of we have the innate R naught, we have this alpha parameter, which is going to be basically societal social connectivity, how much we've suppressed social connections that are possibility of spreading the virus, times the fraction susceptible. And so the important thing here is that let's say through reducing social connectivity, our RT is 1.4 rather than 2.5 if 0% of the population is immune. Then as we build up immunity, you get to this herd immune threshold at about 30% of the population infected rather than 60%. And if we have stronger societal social control of the virus, and we have a RT of 1.2, we need less than 20% immune to reduce the spread of the virus and to control the spread of the virus. And then of course, if we can, otherwise we can just control things completely by social behavior. And the other way to look at this, and I think this is maybe the main figure of the talk, is that that this is just the same exact equation, very simple thing we're looking at here, that we could have something where if we behave 100% as we were in January and we don't take any measures to control the virus socially, then we really need to get to this blue regime where things are suppressed. We really need 60% immune. But there's this line here that as we reduce social connectivity, we need less and less of the population immune to still control things. And so we can get to these sorts of regimes that I think we're actually starting to hit in states that have had a lot of spread. So if we look at Florida, for example, my guess is that we've seen between 15 and 20% of the state having COVID at this point, which is in some ways really a big number and kind of shocking, but I think it's actually what's true. So we've had 550,000 confirmed cases in a population of 21 million. From other serology work that's gone on, we expect to be catching perhaps 1 in 5 or 1 in 6 infections as a case. This is similar to kind of these issues that Michael was talking about. And this is going to be 10 days ago because we're registering things that are not completely recent. So we have about 3 million infections, or 14% in the state 10 days ago. This is a really probably my favored bit of modeling here, where this is using a 1-to-6 ratio, estimating today at this point we have 20% of the state infected. So it might be 10%, but whether it's 10% or 20% is not actually really the main point here. So if 20% of the population has recovered and has immunity, we can behave as though RT is 1.25 and we still get an epidemic that no longer propagates. And so when we're talking about this kind of pretty narrow range of RT, this becomes important. And just as an idea of what might be happening here, that if we kind of go forward a bit farther and we look at closer to the present, we've seen a slight drop in Florida and a more substantial drop in Arizona in their surge of just confirmed cases. And so these drops have been quite recent. If we look at RT, that places RT dropping below 1 at the beginning of July, roughly, for these for Florida and a bit earlier on for Arizona. And I think And then so if we look at societal responses, so again, this is open table restaurant reservations versus Google mobility, we can see that despite this really strong surge in Florida and Arizona, there's not a lot of obvious differences in how people are behaving. We get this dip from June to July, which corresponds nicely with this dip here. But then we see continual declines in July that are really not borne out by the data. We actually have people kind of returning to restaurants in Arizona, and then a very flat Google mobility estimate here. This doesn't include things like actual mandating that bars close, that mandating of mask wearing, et cetera. So there can be other factors going on in this July period that are not being captured by people going out to restaurants and people searching for retail and recreation on Google. But at least as far as that goes, we don't see kind of further reductions here. And so because of this, if we look at this phase plot, we see kind of things going up as we'd expect with RT versus open table as kind of things come back online. We start to see this epidemic surge. People go to fewer restaurants, and then it declines a bit. But then now we've had this recent period, this last month, where RT has continued to drop despite there actually being, again, an increase in use of open table. And then a similar picture for Google mobility, especially in Arizona, where we've seen this continued decline despite not changes in mobility. So the speculation, and I think I'd leave it at speculation at this point, is that at least some of this continued decline that we're seeing is due to buildup of population immunity. And again, that we don't need much. So we've seen a drop of RT from about 1.3 to about 0.9, somewhere in this framework. And if we've gone to a 10%, 20% of the population recovered in these states, that would suggest that maybe 25% of the reduction in spread is actually from immunity, and maybe 75% is from these societal changes. And so this is herd immunity is definitely not the goal, and I'm not at all proposing this. IFR is still something like 0.5%. Getting to 20% of the population having had COVID, it still bears this massive health cost. So that's not at all what I'm intending here. But I'm just trying to explain why we've seen these epidemics wax and wane, and that the idea being that if a region fails at suppressing the epidemic through these societal means, we're going to expect that as the epidemic occurs, we'll build up some population immunity, and this will be a natural repercussion to kind of kick in and help to control things a bit at the kind of levels that we're looking at. And so that's it. I'll stop there and take questions.
Great. Thank you, Trevor. This is going to test my math ability, but let me throw a few questions out your way. Is there some natural homeostasis or equilibrium here that as places begin to get better, they naturally let down their guard? And therefore, if you're kind of making projections based on some assumptions about behavior, it almost sort of auto-regulates in a bad way. As soon as things get better, people begin acting worse.
Yeah, I think that's a really good point. And from the beginning, that's been my statement, that I can predict how the virus is going to behave much more than I can predict how people are going to behave. So here, so you can imagine in this regime where 20% of the population becomes immune, that helps to suppress things. Now that state sees that there's not COVID circulating, and so now you ratchet things up and you open up schools, or you do the next thing. And then that will then kind of push behavioral RT up, and you'll have another epidemic until you've reached this new equilibrium point. I think that's very much the worry.
And you say I can predict the way the virus behaves better than the people, but you can, I think now 6 months, you probably can begin to predict the people. You see what people have begun doing in New York. Mm-hmm. Would it say that they're going to get hit again in New York in the fall because they appear to be forgetting the lessons of March and April, or that they're 20% of 25% of the population being immune should be enough to keep it down, even if there's some recidivism in behavior?
Yeah, it's hard to completely it's hard to model this in that we could say compare New York to Chicago or something like this as we have the seasons change here. And we're going to expect more population immunity in New York that will help to hold things down. But we could also imagine that people in New York have a much more visceral memory of how bad things can be. And so even if you're not kind of capturing things completely in mobility data, et cetera, you could imagine that New Yorkers are behaving more carefully than people from Chicago. And so, so it's hard to exactly pin that down, but you would expect if this 20% of the population possessing immunity does have an effect, that New York will have less of a chance of a smaller ability to have a second wave this fall than say Chicago.
Yeah, I mean, I also note that, for example, an open table reservation is not all the same. I mean, open table reservation in February was you're going to sit in a crowded restaurant, shoulder to shoulder. And an open table reservation in New York may very well be sitting outside, 25% of capacity, whereas maybe in Arizona, it's still, it's still not all that different than it was in February. So some of the metrics of behavior seem, they might be kind of imprecise.
Yeah, I agree. And it does seem that you can actually have economy, society being pretty open and doing a lot of behaviors, going to restaurants outdoors, et cetera. And things are kind of working pretty well. And that doesn't bring RT back up to 2.5. You get to like 1.4 or 1.3 or something like this, with things being quite open because of exactly these mitigating behaviors that people are adopting.
And the model looks like it's, a person is a person, but you can imagine, my parents are in Florida and they're 90 and 84, and they're basically under house arrest. I mean, they're acting very differently than a 25-year-old in Fort Lauderdale. And so how does that, I guess maybe one would say they're equally susceptible. It's just that if my parents get it, they're in for a much more likely to have a bad outcome. But does the susceptibility change at all based on differential behavior by different populations based on their perceived risk?
Yeah, that's a good question. So we have seen a clear shift, and I think most people would agree with me here. We've seen a clear shift towards a younger population being infected in, say, June, July, August, compared to March and April. And I've thought of this as just people behaving somewhat rationally in terms of their own exposure to risk. And so it makes sense that there's been this shift. And that's slightly lowered IFR, and it's had these sorts of repercussions.
So people don't know. So what, can you explain what IFR is?
Oh, sorry. Yes, infection fatality ratio. And so early on, if you look at New York, that was over 1% of the infections. People that were infected died. There are two difficulties in estimating IFR. One is that not every you don't capture every infection as a confirmed case. So you need that kind of seroprevalence or something to be able to go from cases to infections. And then two is that there's this big lag between when cases are reported and when deaths are reported. There's a shorter lag between people actually dying and then a longer lag between the kind of reporting coming in. And so it makes IFR a bit harder to estimate. But at this point, I do think that it's decreased nationally compared to March and April, partly due to better clinical care, but also due to this just shift in age distribution.
Does that change anything in your modeling if the behaviors actually are quite different for older at-risk people versus younger, less at-risk people? Maybe transmissions are the same, but the IFR, I assume, would continue to go down. And again, you wonder, is that going to be cyclical? People say, oh, it's not so deadly, I'm going to go out and party again.
Yeah, it's also a good question. So, wait, sorry. Repeat your question. I've now.
Well, I'm just thinking that of the fact that people are going to act differently based on their perceived and probably their actual risk of having a really bad outcome.
Yes. Okay. So how would I think of that as like this? The best way to model it, which I haven't done much of, and it would take some more careful work, is basically you'd want to start to have these compartmental models where we have perhaps a younger compartment and an older compartment, and you start to break up the population, and we think that the younger compartment will be having a kind of a higher behavioral RT than the older compartments, and then you want to try to measure mixing between those and so forth.
Yeah.
And you probably want that sort of thing as well for things like the difference between Northern Florida and Miami-Dade County, where we're going to expect kind of a higher behavioral RT in these urban areas that will get you to a larger fraction recovered, a larger fraction immune. So your equilibrium point will be a bit farther off compared to the more rural areas of a state.
I've seen some pushback on Twitter, not surprisingly, about this, how if you're saying, if someone can distill this message down, probably overly simplistically, to, all right, we might be hitting a version of herd immunity at 20 or 25%. How do you explain San Quentin prison, where 60% of people are infected, or some of the data you hear is coming out of some of the schools, or even early cruise ships, where you assume there was some behavioral mitigation that started reasonably quickly, and yet they got up to numbers like the 60%. That's kind of the classic herd immunity threshold.
Yeah. So again, I think the argument is that that RT on the behavioral side is very malleable and is very context specific. So if you have a situation like a prison, there's not much you can do in terms of behavioral mitigation of spread, and so you'll naturally have that. That slide of the heat map, you're going to be kind of high up on the y-axis for social connectivity, and you can't really modulate that. So you'll expect that your epidemic will be much larger, and we see that in other places. That definitely, like in Bergamo, for instance, where we have seroprevalence of like 50%. That
cities in Italy. Yeah.
Yes, that we definitely have cases where you can get a large fraction of the population infected, but I think this plays in where the idea is that there are going to be these settings or populations where there is less reduction in social connectivity as you get larger seroprevalence in those areas. And if you have this this mixture, like we're seeing in, say, Florida and Arizona, we get to some kind of intermediate point in both behavioral RT and population immunity.
So maybe my last question. So you've got a ton of Twitter followers. You put that post out there. As soon as you say herd immunity, it pushes a hot button in 1,000 different ways. Mm-hmm. Probably like saying masks or saying Trump or saying anything. It's going to, a lot of people are going to react. So first of all, what were you trying to achieve as you put out this theory, and has some of the pushback been interesting or surprising to you?
Yeah, I think basically, I don't want. To me, it seems clear that we're going to have some effect of population immunity that is helping to control things. What that actual number needs to be dialed in and quantified. But we're seeing we're seeing the epidemics and the surge in Florida and Arizona subside, and I think that, and it might not keep going. It might kind of get to some slightly lower fraction. But I think it's important to try to understand and convey what we think is happening, and that there's some, that it's not just kind of magic that we've had this epidemic subside in these places.
It sounds like not just magic, but also not just that people changed behavior, but that even though you're not at 60%, there's some aspect of herd immunity like the concept of herd immunity is playing out in some important ways, even though you haven't reached the classic threshold, I guess. Is that fair?
Yeah, that's fair. And I think the pushback is basically either that herd immunity threshold is 60%, period, right. That you're wrong, or B, you shouldn't say that because it will encourage people to behave less carefully.
Yeah. What do you? That seems like an obvious pushback. How do you respond to that?
I think from the beginning, I've thought it better. Like this feels like the same thing playing out with masks early on, where if what you want people to do is to not buy up all the N95s so that they can be used by healthcare professionals, it kind of is self-defeating when you say that masks don't work, and then as the strategy to have that desired outcome. And so I think kind of being as scientifically open with people is the right way to be behaving in these in this sort of pandemic, and trying to have as accurate and transparent public health messaging as possible.
Great. Well, thank you for doing that. I think it's been provocative and certainly helped me think about this in a different way. And yeah, it does feel like when you look at those curves and how they've begun to come down, you certainly get the sense there's something more going on than just purely behavioral change. And I guess we'll see how that plays out over the next several months. So Trevor, thanks so much. Keep up the great work and look forward to continuing to hear your thinking on this.
Okay, thank you.
Let's transition to the last segment and bring on Emily and Ashley. I'm not sure if you're both coming on at the same time or just Emily first. I know Emily's speaking first. All right, Emily, the stage is yours.
All right, thanks so much for having me. My name is Emily Silverman, and I'm an internist at Zuckerberg San Francisco General Hospital. I'm also the founder of the Nocturnists, which is an independent medical storytelling community that I actually started up when I was a resident here at UCSF. And I'll be talking for a few minutes about the project I've been working on over the last few months called Stories from a Pandemic. And then after that, I will turn the mic over to my colleague, Dr. Ashley McMullen, who's going to speak about a similar audio series that we're working on together called Black Voices in Healthcare. So before I dive in, I just wanted to provide a little bit of context about the organization that I run, which is called the Nocturnists. So the Nocturnists was really born out of the burnout that I was experiencing during residency, as I feel many residents and even attending physicians are experiencing today, really just feeling like I wanted a space where healthcare workers could come together and examine themselves, pause, take a breath, find space to explore, find space to play, tell stories about ourselves, tell stories about our work. And in January 2016, we did our first live show with a very, very small audience of 40 people and picked up a lot of traction. I think there was just a lot of hunger in the medical community to be engaging with ourselves and with our work through this more humanistic and narrative lens. I think especially as computers have been encroaching on the doctor-patient interaction and just feeling like sometimes medicine can be really creatively stifling, which is unfortunate since I feel like medicine has the potential to be such a creative space. And I think a lot of COVID actually has brought out some of that creativity and innovation. But at the time, really craving this sort of communal catharsis. So fast forward 4 years and we were able to really build on that momentum, and pre-COVID in January, we're fortunate enough to sell out the Yerba Buena Center for the Arts in San Francisco. It's a 700-seat theater. We filled it up and had physicians and other healthcare workers telling stories about themselves on stage. Around that time, we were also doing a podcast spinoff. And so the way that the podcast was working at the time was the first half of the podcast was a live story clip from one of our live shows. And then it would be followed by a conversation between me and the storyteller. So this is what we were doing. We were actually in our third season of this podcast when COVID-19 hit in March. And we just dropped everything. And our team looked around at ourselves and we were like, wow, our organization has never made more sense than it does right now. Because we had really been spending 4 years taking care of the hearts and souls of physicians. And we saw that we were facing what in many ways is one of the biggest plot twists in medical history, and really wanted to make ourselves available to serve our community and to continue to be a space and an outlet for self-expression and for healing and for community and for well-being. So what do we do? So what we ended up doing is putting out a call for audio diaries. And this was different from what we had been doing before, because previously we were asking healthcare workers to come into our team and craft like a perfect 10-minute story with opening scene and an arc and stakes and conflict. But this was like, come home from work, turn off the lights, talk into your phone, don't prepare, don't write, don't think, just tell us what's happening, tell us what's on your mind. And so we put out this call, and within about 24 hours, we had 50 people sign up. And then over the course of the next few weeks, we actually ended up having over 200 people sign up to participate in this project. People from all across the United States, a lot of physicians, but also some nurses. We had a chaplain, we had a DME, medical equipment truck driver sign up to participate, all sorts of voices. And we effectively received, I want to say, 700 audio clips between the months of March and May. And so our team would sit and just listen to these audio clips, listen to what was going on the ground, and started to produce these episodes, podcast episodes. And we produced them in the style of Saturday Night Live, where basically every Tuesday we would release an episode, and then the clock would reset, and we would look at the material that had come in the week before and try to pull out themes that were coming up, try to highlight contradictions that were coming up, and really just keep our finger on the pulse of what was happening on the ground and pump out these episodes every week. And it was great because the audio diarists who were contributing could hear their own voices on the show in real time and could hear the voices of strangers across the country who were going through this experience alongside them. And what was also interesting about it is that each audio clip itself isn't necessarily a full story. There are these moments, these slices of life, and when you weave them together into a tapestry, this larger story starts to emerge of what is it to be a healthcare worker, during COVID-19. So this is what we did, and the question comes up: why is this important? Why is storytelling so important during a pandemic? And I think in medicine, a lot of us tend to focus on the science and the data, and that is hugely important. I think even some of the other speakers today are showing us the importance of epidemiology and tracking and evidence and all of that. But I also think it's really important for us as a medical profession to just take a breath and just locate ourselves in the chaos of what is happening right now and ask ourselves, how are we moving through this moment? What is coming up for us? Where are we sad? Where are we angry? Where are we frustrated or lonely? Where are the moments where we're finding joy, where we're finding hope, where we have moments of triumph? Where are the moments of complexity and contradiction? For example, we had a diarist send in a clip from Indiana, and his wife was undergoing chemo for cancer, and he was a pulmonary critical care physician and wasn't going to go in to take care of COVID patients because he wanted to protect his wife, who was immunosuppressed. And he was really conflicted about it. I mean, on the one hand, he was relieved and he was glad that he didn't have to go in and put himself exposed to this virus. On the other hand, he was having like FOMO and, kind of wanted to like jump in and lend a hand. And it was all of those feelings layered on top of themselves simultaneously. And I think what's really been great about this project is we've been able to give voice to that emotional complexity and give people the opportunity to really metabolize this experience and create meaning out of this experience. Storytelling is a very powerful tool for making meaning, and also to do that communally, to do that as part of a larger group, particularly a group of other healthcare workers who kind of get it and understand what it is to be going through this, is really powerful. So just briefly, I just wanted to touch on some common themes that came up as we were listening to this audio, since people ask a lot about that. Early on, there was a lot that we were hearing about fear, about uncertainty, about bracing for this tidal wave. There was a lot coming in about leadership and what it means to be an effective leader during this time. How do we communicate with each other about new policies that are ever shifting? Who were the people who felt they were being led well? Who were the people who did not feel like they were being led well? There was a lot about loneliness and social isolation, the deep need that we have to touch each other and to connect to each other face to face. There was a lot that came up around the concept of sacrifice, around the identity of being a physician and the rhetoric that was being used in the mass media about doctors and nurses. all of these military metaphors that are being tossed around, like going to battle or being drafted. So that came up a lot. Questions of guilt, questions of how do we assign value to things in healthcare, questions of health equity, as we saw how this pandemic ripped through our most vulnerable patient populations in this nation. And then toward the end, questions of where do we go from here? How do we use this historical moment as a fulcrum to really pivot and rewrite the future and give us a different American healthcare, one that is more equitable, one that is more sustainable, one that is more healthy. So in terms of where we're going from here, we're gearing up. So we did the 10 podcast episodes, which you can listen to. It's an audio documentary series on our website, thenocturnist.com. And then we have an interactive story map where you can listen to the stories by geographic location. And we're currently in conversations with a major cultural institution, which I can't name at this moment, but talking about enshrining this audio library as a historical document to be preserved, which can be accessed by historians in 100 years, which I also think will be really important. And we're going to continue to collect audio. So if you or anyone you know is interested in contributing, please feel free to reach out. We're going to produce a part 2 of this series. And so maybe I'll just pause there. I think one of the best ways to really get a flavor of what we're doing is to listen to an audio clip. And so I've selected this clip. It's just under 3 minutes. It's short. Thank you for transitioning to the slide. This is our beautiful art that was done for the project by illustrator Lindsay Mound. And I might just ask that you take a breath, close your eyes, listen to the story. This is a clip that was sent in from an internal medicine physician named Kat from Michigan a couple of months ago. And I think you'll see, hearing the clip, just how much she brings us into her world, into the hospital. And so let's roll the clip.
Today is April 26th. It's a Sunday, 5 o'clock. And yeah, I'm in the hospital even though I'm supposed to be off, but I don't care today. Because I am walking through the basement and I'm looking at a unit of convalescent plasma. Like, I'm holding it in my hand and walking it to the ICU right this minute. Because my hospital is lucky enough to be one of the sites for research that we've got something in our arsenal that we think really works. And it's really cool. I've watched everybody perk up at each stage of this process of, hey, we got registered as a site. Hey, we consented and enrolled our first candidate. But now that it's here, now that I'm looking at it, it feels going up so much better. When I go in to consent another person in another room while we're waiting on it to thaw, I feel hope. We feel energized. And so I think that's what we all need right now, because the hope and the energy is losing it. But, you know, it's those little things. The patient that we discharged from the rehab unit to go back to his family, who was up and walking and gonna be like his normal self, that was a win too. That was a good one. So yeah, I'm really excited to walk through the ICU doors and go hand this off to the nurse who's gonna hang it for our really sick, prone, ventilated patient who happens to be one of my primary care patients through sheer dumb luck. Today's a good day. I don't mind being at the hospital today. Just left the hospital. And the sun is out. It's gorgeous outside. But the best thing, the very best thing, is the refrigerated trucks are gone. None of us wanted to talk about why they were there in the first place. And we're still going to lose patients. There's no question there. But things are starting to feel more like we can handle the bad stuff and that there's more good stuff.
So that gives you a taste of what we've been collecting, the type of audio we've been collecting. If you're interested in learning more, you can visit our website, thenocturnists.com. And thank you for your time and attention. And I'll just turn it over now to Dr. Ashley McMullen, who will talk about our other series, Black Voices in Healthcare.
Great, thank you.
Great. All right, thank you, Emily. So yeah, the next series of the Nocturnists has been Black Voices in Healthcare. And really the idea for this project came out of in the wake of the George Floyd murder, which was at that time just the latest in a series of examples of anti-Black racism in our society. And while this isn't new, it definitely hits differently in the context of a pandemic that is certainly disproportionately impacting communities of color, especially African-American communities. And so recognizing that, in this moment specifically in healthcare, what we need is not only a greater awareness of these issues, what we need is empathy, and certainly empathy across differences. And stories are just one avenue to do that. And so that is kind of the motivation behind launching this series. And so I actually would love to just go ahead and transition into a clip from one of our episodes. Again, similar to the last one, it's going to be just under 3 minutes, and then I'll jump back on with a couple comments after that.
I still remember the day I met her on rounds. I'd taken over our service on the inpatient HIV service, and she had been in the hospital about 30 days. Young girl, advanced HIV/AIDS, battling a couple of opportunistic infections, and she was starting to finally get better. She was being weaned off oxygen and was starting to regain her appetite. We had started her on antiretroviral medicines in the hospital. I remember meeting her, and she's probably 24, 25, slightly older than my kids. And all I could remember was how little she looked and how much hair she had. Her hair was big, it was huge, but it was matted. And she'd been in the hospital, she'd been in the ICU, and through all of that, the transfers back and forth, no one looked at her hair. I've spent many years in the hospital. I'm used to bringing in little hair ties and getting out the little rubber bands on my wrist to give to a patient, because I know Black women, our hair is important. Our hair is part of what defines us. And when people are in the hospital, a lot of times, that just falls by the wayside. The little bowls at the bedside with the one shaving stick and little tiny comb doesn't cut it. It never has, it never will. And there's nothing like having your hair done to make you feel like you're getting better. But this one girl, young lady, was just finally getting better. And I told myself I would braid her hair. I'd never done that for a patient, but there was something about her. She had this fight in her eyes that she was going to get better. And I know that just feeling better about how she looks would help. So I asked her how she liked her hair, and she said, she always got her hair done, twists, braids, different things. So Saturday morning, we got done our rounds. It's pretty early. We didn't have a lot of admits. We were pre-call. And I just went into her room and I said, hey, do you want me to braid your hair? She was surprised. She said, doctor, you're going to? I said, sure. I said, I've been braiding my sister's hair for a long time. I have 3 younger sisters. I have 2 daughters. Both my daughters used to fall asleep with me braiding their hair. I like to tell myself that my hands are soft. I sat by the bedside and I braided her hair into 8 cornrows to the back. She looked fabulous.
Awesome. So what you guys heard in addition to that clip, or what you saw, or what you're seeing now, is the beautiful artwork we have for our illustrator for this series, which is a piece by Ashley Floreal. So in that clip, it's actually one of my favorite stories of the series, but you hear from a Black physician who's caring for a Black patient who's been ill for quite some time. And The idea being that she's able to establish this connection that kind of sees the patient beyond just a series of illnesses, but really allows her to touch on that piece of her humanity and recognizing that hair is a big part of Black identity, especially for Black women. And so being able to do her hair played a role in that patient's healing. And again, just elevating the humanity that can sometimes be absent in medicine. And so really the hope for the series is that it allows listeners just a greater proximity to the Black experience through the lens of Black healthcare workers, and highlighting not just the pains and difficulties that come with being Black in our society, but also the joys and the strengths and the triumphs, and also just the complex humanity that really connects us across differences. And specifically as people who work in healthcare and are working during this unique time in the context of COVID-19. And so again, hoping that by listening, by having this proximity, by gaining better understanding and better empathy, it can start to lower some of the barriers to having the difficult but necessary conversations that we need for lasting change in this moment and going forward. So with that, I want to turn it back over to you, Bob, and hopefully have some time for questions.
Maybe if Emily can come take down the slide, and if Emily can come back on, and there's time for just a question or two. Thank you both. It's incredibly powerful, and the whole series has been just great. I remember when Emily started this, or we had a conversation about this on a drive from one of the hospitals to the other. You had some sort of dreams about what it would become. Can you talk about sort of whether you're reaching them, and what if 3 to 5 years from now this even exceeded where it is now, what would that look like for you? And maybe for both of you, actually.
Sure. I would just love for the Nocturnists to be the place to go to access really compelling, provocative stories about what it means to be a healthcare worker in the United States. I almost dream of it being like a This American Life for medicine specifically. And I think what's really unique about this project is it's by healthcare for healthcare. When I went into this project, I wasn't a journalist and I was an MD, and it was really born out of my own hunger to create the space for MDs, and then later expanded to RNs and other healthcare workers. And I find that when people share audio with me, the fact that I and a lot of the others on the team are doctors, like there's sort of this different way of talking to each other. I just noticed that when physicians speak to journalists or the lay press, there's this like filter there. But when you're talking to another doctor, you kind of get each other, as I said, and you can talk in a certain language. And I think that's one thing that makes our project really special, is the way that we've been able to build that trust and camaraderie and really not be afraid to explore our own vulnerability. And I think to do that with another physician organization as a guide would be really powerful.
Great. Ashley, what's your dreams for this?
Yeah, well, I guess my first dream is that we can do live shows at some point again, and that will be exciting. I think, as far as my hope, especially with the series, is that it's just one catalyst to integrate more narrative into how we practice, both in the way that how we see our patients, and also the narratives that we tell among our colleagues, to again kind of get us out of these professional silos and recognize that there's so much humanity and so much depth in the storytelling experience that happens in medicine. And I think that just makes us better at what we do.
Well, thank you both. It's really powerful. And throughout this entire thing, it's increasingly clear that the number of lenses that we have to use to look at this and get it right is extraordinarily large. And if you're just looking at it through the quote scientific lens, you're missing a ton. And just the power of what you've shown us today is it really demonstrates that quite clearly. And I hope people will go to the site and listen and contribute. And also I hope we have live shows sooner rather than later. So thank you both for being here. Let me thank all the speakers. Again, a reminder that next week for UCSF folks, our Grand Rounds will be replaced by a presentation at the same time by the campus looking at the future of Parnassus. We'll take a couple weeks off after that, including the production team, as you see here. They get a little bit of break, and we'll be back on Thursday, September 10th, with another in the series. We'll post this tonight on YouTube at about 7:30 Pacific, and we'll have a good copy of the first video. So thank you all for joining us. Stay safe and sane, and hopefully we're moving closer to the end as we go forward. We'll see you in a few weeks. Thanks so much.